Hello. I would like to thank the organization committee for the invitation. I'm very grateful to be here. I will also take the opportunity to introduce to my colleague, Magnus Hallbäck, who's sitting just beside, so behind Jan, who is the man behind the capital dynamics. He invented it, he designed it, and made a mathematical programming in MATLAB. So he is the guy you should thank later on. So what's capital dynamics? It's cardiac output just a breath away, was the question mark. And was that wrong? Okay, sorry, I found it. It's something we have developed during close to 15 years, and we have utilized a Survive ventilator with a slightly modification. And this picture came from one of our adult clinical studies at the Karolinska University Hospital, and this is one of our PhD students taking care of the patient. So the capital dynamic method is a continuous, non-invasive, differential Fick method whose primary intended purpose is to measure effective pulmonary blood flow, which equalize to cardiac output when the shunt is eliminated by, for instance, a recruitment maneuver. It also measures end expiratory lung volume by CO2, which differs from the end expiratory lung volume measured by inert gases. So it's a measure of FRC continuously. But also the latest achievement is that we actually are able to measure mixed venous saturation by ventilator and carbon dioxide kinetics. And this is aimed to be used during major surgical procedures and intensive care. And the concept behind this is the differential Fick method. It says in NAN, the Bible for applied respiratory physiology, that the storage capacity of carbon dioxide is large compared to the production and tissue, in the tissue and extraction. And it can be described in this picture, where you can see that the elimination is about 200 mils, and we have a storage in the body close to 15 to 70 liters of carbon dioxide. This means that the variability in the short term of mixed venous partial pressure of CO2 is very low. And that's what we utilize in the differential Fick methods. And it's important also to remember that cardiologists and physiologists still deem the Fick's principle as the golden standard for assessment of perfusion of an organ, for instance, the heart. So we have this ordinary Survive ventilator, which we have CE marked with an R, because we are now able to introduce a special breathing pattern. Sorry, that's not the meaning. So which you can see over here, it's a little bit dark, but we have 3 breaths with an extended expiratory pause. Otherwise, we have 6 breaths, which is totally normal. And so this is the only thing we do. We add these 3 expiratory pauses, which you can see over there. The pauses creates a rise in the alveolar fraction of carbon dioxide due to, during the pauses, lower carbon dioxide elimination. So by having this kind of pattern of the concentration of CO2 in the lungs, we are able to get lots of information from the patient. The capital dynamic method contains of 3 mathematical modules. Here we have the primary thing, which is most important, is that we are very precise, can determine the carbon dioxide elimination breath by breath. This needs by the volumetric capnogram, and this needs a perfect synchronization between the gas concentration and the flow. So this is otherwise a source of error. We also have the solubility concentration to find out the content of CO2 in the blood, which is depending on the partial pressure, HB, and also the saturation of oxygen. Then finally, we have a rather simple lung module, one lung compartment, but we have more compartments in the anatomical dead space. So we have the lung volume, we have the content of CO2, and we have the pulmonary blood flow, which is the effective pulmonary blood flow, which is the part of the cardiac output that participates in gas exchange. This gives us possibility to create the capnodynamic equation, which is an equation where we describe the mole balance across the lung. And the left side, we have the content in the lung and the difference in the content between two breaths. And during the same time, we have the supply from the blood of carbon dioxide into the lung. And then we have the elimination from the current breath. And this is three unknown: the end-expiratory lung volume, the effective pulmonary blood flow, and the content of CO2 in the veins. And this gives a possibility, since we have 9 breaths, we have 9 equations, we can solve out these three unknown in an overdetermined equation system. This is a slide of the research window. It's not aimed to be something we should have in a commercial product. So it gives you lots of physiological information. I begin with a volumetric capnogram, which when it has a very flat profile, means that the lung is well recruited. This slope tree is related to how homogeneous the lung is. On the right side of this one, we have, I don't think if you can see the blue dots or black dots. You see it? Not possible. It's the red line is describing the expected variability of the CO2 content, CO2 partial pressure in the lung, and the blue dots describes exactly how well next breath will fit with the prediction. Here we have the lung volume, and here we have the cardiac output effective pulmonary blood flow. We also have here compliance, and we have the PEEP. What we have done here in a boy with a lip palate surgery is 8 kilogram. We have made a PEEP step, and the PEEP step creates an increase in the lung volume and a decrease as expected in the pulmonary blood flow. This was published, this was the first clinical study, and this was published in British Journal of Anesthesia for a couple of years ago. And the problem with clinical studies is to how to find a good reference to see if your new method is working well or not. So we took the most experienced pediatric cardiologist who was doing suprasternal Doppler on the kids, and he was blinded to the result from the capnodynamic method. And when we analyzed the data, we saw a drop during the PEEP step from the capnodynamic method, but we couldn't find it in the suprasternal Doppler, which was a little bit surprising and also a little bit troublesome. So we went to the animal lab, and all our animal experiments is performed at Göran Hedenstierna Laboratory in Uppsala, north of Stockholm. So when we went to the pigs, we could find out that our expected pattern behavior from the PEEP step was reproducible in the pigs when we used a transonic probe directly mounted on the pulmonary artery. So we found out that the problem with the clinical part of this study was that when you increases PEEP, you changes the angle of the heart and you changes the position of the heart, which makes suprasternal Doppler measurement more complicated. Also worth to mention here is that the inherent precision during baseline from the suprasternal Doppler was about 12%, which was not so good as the inherent precision for the capital-dynamic method. So this was a problem that we couldn't really rely on our reference method. The next clinical validation study was performed in adults during major abdominal surgery. They were scheduled for more than 8 hours of surgery, 8 to 12. It was mainly complicated colon tumors, which were operated both in prone and supine position. And this is a trace from one of the patients where I actually had a hemorrhage for 600 mils. A pelvic artery was ruptured during the procedure. And we can see that mean arterial pressure dropped promptly, and also the effective pulmonary blood flow followed this pattern, but the pulse contour analysis didn't react as much as the other parameters did. So the question was this something wrong with the pulse contour, or was there something wrong with our method? And we have experience from previous animal studies that we have a very rapid response time. The response time is depending on the respiratory rate. So we had a response time between 20 to 40 seconds depending on the respiratory rate. This is a very good intervention you can do in the animal lab, is that you put a catheter in the caval vein and you have a balloon catheter. So you inflate the balloon and promptly decrease preload, and then you see the response time compared to the transonic probe, which is the red one, the effective pulmonary blood flow. It's slightly slower, but still very rapid. And when they do the deflation, it also very quickly recovers. So from this history, and we had some other cases which also had a huge bleedings where we couldn't find a rapid response from pulse contour. So we went to the lab again and created a model of standardized blood volume changes. Piglets, about 2 months old, they have a blood volume about 77 milliliters per kilo. So what we did was we took these pigs, we drained them for 50 mils of blood, waited either 5 and 15 minutes for measurements, because the pulse contour maybe had slower response time compared to our methodology. And then we gave a fluid, crystalloids, same amount, and you made the same measurements, 5 to 20 minutes. And then we waited an hour to get a redistribution of the crystalloid into the tissue before we gave the blood back to the piglets. With the help of Professor Robert Hahn from Stockholm, who have studied a lot of fluid kinetics, it's possible to actually determine the blood volume intravascular. So we can see that the blood volume drops significantly, recovers a bit because of redistribution of intestinal fluid, and then we give the bolus, and then we give the blood. So we can follow this very well. And we can see that mean arterial pressure have about the same pattern. PPV act as expected, because these pigs were also ventilated by 10 ml per kilo, since they are very hypermetabolic as meat production pigs. The stroke volume from the pulse contour didn't react at all, more or less. And if you go into look at what happens with the EPBF, you can see it has very significant changes according to the blood volume. But if you look at the pulse contour, it's a huge randomness and have very little of systematic changes following the blood volume changes we have induced. And this is reflecting when you divide this cardiac output with the heart rate, then we get the stroke volume, and the stroke volume from EPBF was following the blood changes very well, but also the stroke volume from the pulse contour methodology didn't perform well. Another way to see this is to look at the correlation plots. So if you see here, this is the EPBF and this is the pulse contour, which is more or less don't have any really correlation. This is the blood pressure, which is good to know that our old blood pressure measurement, the MAP, is still valid during intravascular volume shifts. The correlation for EPBF is about 78, but if you take away the randomness by making a mean, you can see that we have a correlation of 99% for both the EPBF measurement, but the correlation for the pulse contour is negative, and actually, if you see here, it goes in the wrong direction. And the thing is that we thought it was a new finding, but this is already published for Litko in 2007, where they invented hemorrhage due for dogs, and found also that the pulse contour methodology actually didn't pick up the bleeding. By adding the RQ, respiratory quotient, is something that is basically from the cellular level, and it's nutrition dependent and actually not something dependent on oxygenation and things like that. We have to be aware about respiratory exchange ratio, which is the rapid changes in carbon dioxide elimination due to, for instance, acidosis and things like that, doesn't reflect the respiratory quotient, which is based on our basal metabolism. So by adding an RQ, we are able to calculate the oxygen uptake by dividing the carbon dioxide elimination with RQ. EPBF is a fixed principle content, and we can redistribute this formula to the content oxygen is the capillary content, and the oxygen uptake divided by EPBF. Mixed venous content is depending on the partial pressure and also the HP. And from this mathematical formula we can sort out the mixed venous saturation, which is thus able to calculate and measure by the capillary method. So we took the same animals actually from the first study, and we were investigating this for rather minor clinical challenges, because this was the same protocol. So we just increased the peak, but we were able also to see that we had a good correlation and good agreement between the pulmonary oximetry based on the blood gas analysis. And it's the same formula here. And then we got criticized from some reviewers that we didn't have major changes, so that's why we made this standardized bleeding procedure. So this is the same animals, so you can recognize here the bleeding part and the fluid, but we also added the caval balloon and the butamine, and we have a baseline. And during the baseline part, we are able to measure the inherent precision, which is depending on the variation coefficient. And the variation coefficient, or the inherent precision, is similar between the capno mixed venous saturation and the fiber optic mixed venous saturation. And actually it fulfills the requirement for point-of-care analyzers. So the next step was to follow this, and we could find out that capno in these major hemodynamic changes actually had a concordance of 98%. and the fiber optic was in the same size. Finally, we have a paper on the revision now, which we made together with some colleagues in Sydney, in Australia, where we looked for the agreement and the validation of the capnodynamic method in a patient after cardiac surgery. The primary aim was to look at the agreement, not the trending, because we didn't have ethical permission for any trending studies. We used RQ.85, which is based on historical published data. We had 47 patients. We have, in this study, synchronized the measurement at 4 different PEEP steps. This all should be taken within 5 minutes because it's a rather dynamic situation. So if you are on a slope and you have 10-15 minutes between samples and the measurement of the capnodynamics, then you could be fooled. We used Blent-Altman for repeated measurement. Based on our previous studies, we claim that because the reference is not perfect, the reference have the same inherent precision as the capnodynamic method, we claim that we should have limit of the agreement between 10%. And what we found was that we have a very good agreement, more or less within 1% point, and the percentage error was always below 20%. And we also compared EPBF with cardiac output, but it's important here to remember that this is a little bit to compare apples and pears, because EPBF is not exactly the same thing as cardiac output, because cardiac output is including the shunt. So EPBF is cardiac output minus a shunt. But when we compare mixed venous saturation, we have the same entity to compare with. So the reason why we have better percentage error and agreement is that we here really compares exactly the same thing, and also that the blood gas analyzer has a better inherent precision compared to thermal illusion, which always is about 10% in inherent precision. So from this we can say that our determination of carbon dioxide elimination and EPBF likely is very good, because since we have so good agreement here between these two. And remember also that it's the effective pulmonary blood flow which is important for oxygen delivery and also carbon dioxide elimination. The shunt flow doesn't add any value. So this is the Blent-Altman plot. Worth to mention here is that this outlier here was related to the blood sample, likely to air in the syringe or as to small sluice volume, because all other samples from that patient was in line with the capnodynamic measured values. So this was linked to the reference method, this outlier, and this describes that it's tricky to do this kind of agreement studies in the clinical situation, and be aware that the reference methods are not perfect. So the capnodynamic method is promising, but has a limitation. It's that it requires controlled mechanical ventilation. But it has strengths. It doesn't add any clinical hazards. It's simple to use, does not require any training or calibration. It continues, gives you breath by breath new measures, and have a short response time. And it's suitable for infants and pediatric patients, where it actually today doesn't have so much alternative for cardiac output monitoring. It's also very suitable for trauma patients, where after about 1 minute after you have intubated a patient, you can get your first measures of stroke volume and mixed venous saturation. One important thing is also that the capnodynamics mixed venous saturation is a prediction what you will receive if this cardiac output stands during a longer time, because it reacts on the figures it has, and it reacts a little bit quicker than the physiology. So it's in some way a prediction tool which can be very useful, especially in trauma cases or during unexpected bleeding during surgical procedures. So then I just do like this and say the capnodynamic method means that we have effective pulmonary blood flow and mixed venous saturation just a breath away. Thank you for your attention.